Hello, it's Dmitriy again. We'll be reading again from the Blueprints Psychiatry 5th edition textbook, talking about Chapter 12, Antidepressants and Somatic Therapies. So let's begin. Antidepressants are used commonly in medical and psychiatric practice. As a class, antidepressants have in common their ability to treat major depressive illness. Most antidepressants are also effective in the treatment of panic disorder and other anxiety disorders. Some antidepressants effectively treat obsessive-compulsive disorder, OCD, and a variety of other conditions. See indications to follow. The most commonly prescribed antidepressants are listed in Table 12.1. Antidepressants are subdivided into groups based on the structure of prominent functional activity. Selective serotonin reuptake inhibitors, or SSRIs, tricyclic antidepressants, or TCAs, and monoamine oxidase inhibitors, or MAOs inhibitors, and other antidepressant compounds with a variety of mechanisms of action. Antidepressants are typically thought to act on either the serotonin or the norepinephrine systems, or both. Figure 12.1. Choice of medications typically depends on diagnosis, history of response in patient or relative, and the side effect profile of the medication. Antidepressant effects are typically not seen until 2 to 4 weeks into treatment. Side effects must be carefully monitored, especially for TCAs and MAO inhibitors. Indications. Table 12.2 lists the indications for antidepressants. The main indication for antidepressant medications is major depressive disorder, as defined by the Diagnostic and Statistical Manual of Mental Disorders, DSM-4. Antidepressants are used in the treatment of all subtypes of depression, including the depressed phase of bipolar disorder, psychotic depression in combination with an antipsychotic medication, atypical depression, and seasonal depression. See Chapter 2. Antidepressants are also indicated for the prevention of recurrent or depressive episodes. Antidepressant medications may be effective in the treatment of patients with dysthymia disorder, especially when they are dysthymia disorder, especially when there are clear neurovegetative signs or a history of response to antidepressants. Panic disorder with or without agoraphobia has been shown to respond to SSRIs, MAO inhibitors, and TCAs, and high-potency benzodiazepines, alprazolam, and clonazepam. OCD has been shown to respond to the serotonin-selective tricyclic clomipramine, anafranil, and to the SSRIs at high doses, that is to say, fluoxetine at 60 to 80 milligrams per day. Obsessions tend to be more responsive to pharmacotherapy than compulsions. Symptoms of OCD respond more slowly than symptoms of major depression. Trials of 12 weeks or more are needed before a medication can be ruled a failure for a patient with OCD. The binging and purging behavior of bulimia has been shown to respond to SSRIs, TCAs, and MAO inhibitors in several open and controlled trials. Because SSRIs have the most benign side effect profile of these medications, they are often the first-line psychopharmacologic treatment. Mechanisms of action, I should say. Antidepressants are thought to exert their effects at particular subsets of neuronal synapses throughout the brain. Their major interactions is with the monoamine neurotransmitter systems, dopamine, norepinephrine, and serotonin. Dopamine, norepinephrine, and serotonin are released throughout the brain by neurons that originate in the ventral brain stem, locus coeruleus, and the raphe nuclei, respectively. Figures 11.1, 12.1, and 12.2. These neurotransmitters interact with numerous receptor subtypes in the brain that are associated with the regulation of global state functions, including appetite, mood states, arousal, vigilance, attention, and sensory processing. Table 12.1, commonly prescribed antidepressants. So with the drug name and the brand name in parentheses, we have the usual daily dosage and the extreme daily dosage. So fluoxetine, also called Prozac, usual is 20, extreme is 80. Sertraline, are also called Zoloft. These are all SSRIs so far. So sertraline, Zoloft, 50 to 150 is a normal daily dosage. The extreme is 300. Paroxetine, also called Paxil, normal daily dosage is 20. The extreme is 50 milligrams. Fluvoxamine, also called Luvox, the normal is 50 to 100 milligrams. 50 to 150 milligrams. The extreme is 300. Citalopram, or Celexa, The normal is 20 to 40. The extreme is 60. Escitalopram or Lexapro. The normal is 10. The extreme is 30. And just a little elite ball knowledge for you. Escitalopram is called that because it's specifically the S enantiomer of citalopram, and so it should be significantly more potent, the citalopram is itself, and that's why it's only 10 milligrams as its normal daily dosage as opposed to 20 or 40, and why the extreme is 30 milligrams as opposed to 60 milligrams, because literally we're taking the effective half of citalopram. So if citalopram has R citalopram and S citalopram, we're taking all the S citalopram, i.e. the escitalopram, and using that, and so it's basically twice as potent, twice as effective, because we're not using the ineffective R citalopram. Make sense? Next, the serotonin norepinephrine reuptake inhibitors, or the SNRIs. We have venlafaxine, which is also called Effexor. The normal daily dosage is 75 to 150. The extreme is 450. Duloxetine, or Cymbalta, the normal is 40 to 60. The extreme is 120. Serotonin receptor agonists and antagonists. We have trazodone, also called Deserel. Normal is 200 to 400. The extreme is 600. Nifazodone, the normal is 200 to 450. The extreme is 600. Norepinephrine dopamine reuptake inhibitors. So these are going to be bupropion, which is an interesting drug. It's an interesting, unique kind of situation. Also called Wellbutrin. The normal is 200 to 300 milligrams. The extreme is 450. Tricyclic antidepressants, or TCAs. The normal, let's talk about nortriptyline, or Pamelor. The normal is 75 to 100. The extreme is 150. Imipramine, also called Tofranil. The normal is 150 to 200. The extreme is 300. Desipramine, or Norpramin. The normal is 150 to 200. The extreme is 300. Clomipramine, also called Anafranil. The normal is 150 to 200. The extreme is 250. And bear in mind, for exams, you're typically going to want to know the standard name like nortriptyline, imipramine, desipramine, clomipramine, and not necessarily the brand name. Although, realistically speaking, you probably should know that as well. It just won't pop up in test questions necessarily. Monoamine oxidase inhibitors, or MAO inhibitors. We have selegiline. That's a well-known one, I believe. M-SAM patch. The normal is 6 to 12 milligrams. The extreme is 12. We have transcyclopramine, Parnate. The standard is 30 to 50, while the extreme is 90. Phenelzine, or Nardil. Normal is 45 to 60. The extreme is 90. Isocarboxazid, or Marplan. The normal is 30 to 50. The extreme is 90. Other antidepressants, mirtazapine or Remeron, the normal is 15 to 45. The extreme is 60. And there's a little A here at the bottom. It says, it's just an explanation. I don't know where A was mentioned before. So let's see if we can find that briefly. Not quite sure. Well, maybe you caught it. Maybe I didn't. I don't see it here quite. I must have missed it somewhere. But the little A here, the indication says, geriatric patients generally require lower doses. Okay. So let's continue with our chapter here. SSRIs act by binding to presynaptic serotonin reuptake proteins, thereby inhibiting the reuptake and increasing the levels of serotonin in the synaptic cleft. TCAs act by blocking presynaptic reuptake of both serotonin and norepinephrine. MAO inhibitors act by inhibiting both the norepinephrine presynaptic enzyme, monoamine oxidase, that catabolizes norepinephrine, dopamine, and serotonin, thereby increasing the levels of these neurotransmitters presynaptically. Figure 12.3. These immediate mechanisms of action are not sufficient to explain the delayed antidepressant effects, typically 2 to 4 weeks. Other unknown mechanisms must play a role in the successful psychopharmacologic treatment of depression. So what they're saying is, we know some of the mechanisms that are involved for why they affect the way they do, but not really the whole thing. It's sort of a black box a little bit, sort of a gray zone. So here's another picture of the brain. Figure 12.1, the noradrenergic diffuse modulatory system arising from the locus coeruleus, the small cluster of locus coeruleus neurons, project axons that innervate vast areas of the central nervous system, including the spinal cord, cerebellum, thalamus, and cerebral cortex. So you can see the cerebellum right there in the back. You can see the signal going out from the locus coeruleus to the spinal cord, to the cerebellum, going over to the temporal lobe, going over through and going to the hypothalamus, going to the thalamus, and going to the neocortex as well. And basically, just for reference, when we think about epinephrine, what's another name from epinephrine? Adrenaline. Where does adrenaline come from? It comes from the adrenal glands, right? From the adrenal glands, yes. Now, the noradrenaline is also called norepinephrine. That comes not really from the adrenal glands per se. The adrenal glands are mainly producing the epinephrine type. The norepinephrine, a lot of that's coming from the locus coeruleus, and so that's going to go that's basically in that sort of region of the brain, the locus coeruleus. So it's a different origin. And the way you can remember that is, of course, epinephrine is also called adrenaline, and adrenaline's in the adrenals. The norepinephrine is noradrenaline, and it's not that there's no such thing as a noradrenal as far as I'm aware, but it's certainly north of the adrenals, which is, what's north of the adrenals. Eventually go north enough, it's going to be the brain. So, and that's a sort of a silly one to think about, but that's, whatever. Remember however you find to be most fit and sensible, and, whatever's appropriate, okay? Serotonin system. Okay, so let's read this. The serotonergic diffuse modulatory systems arising from the Raphe nuclei, which are clustered along the midline of the brainstem, project extensively to all levels of the central nervous system. So we have these Raphe nuclei. So it's not like one particular nucleus. There's multiple Raphe nuclei, and they're giving off this sort of serotonin, and it's going to the cerebellum, it's going to the thalamus, the hypothalamus, the temporal lobe, it's going to the neocortex, going to the basal ganglia. So like the norepinephrine pathway, it's kind of going across the entire brain and going down to the spinal cord. However, it has a different origin. When we think about serotonin, think about the Raphe nuclei. When we think about norepinephrine, think about the locus coeruleus. They have a lot of the same destinations, but not the same origin. Table 12.2, indications for antidepressants. So what are they effective for? What are antidepressants we're talking about? What are they effective for? MDD, major depressive disorder, bipolar depression, acute treatment, panic disorder, social phobia, generalized anxiety disorder, PTSD, post-traumatic stress disorder, obsessive-compulsive disorder, that is to say, clomipramine and selective serotonin reuptake inhibitors are useful for OCD. Depression with psychotic features in combination with antipsychotic drug, bulimia nervosa, neuropathic pain, tricyclic drugs, and noradrenergic reuptake inhibitors. Insomnia, that is to say, trazodone and amitriptyline would be useful in insomnia, those two. Enuresis, imipramine is the best studied for this purpose. Atypical depression, selective serotonin reuptake inhibitors, SSRIs, or MAO inhibitors are useful for atypical depression. ADHD, so attention deficit disorder with hyperactivity. Well, I guess that would be ADD with hyperactivity. You would think, whatever. Attention deficit disorder with hyperactivity, that is to say, you can use desipramine or bupropion for that. Probably effective. It might be useful for narcolepsy. Antidepressants may be useful for organic mood disorders. They might be effective for pseudobulbar affect like pathological laughing or crying. And they also might be possibly effective for a few other things. They might possibly be effective for personality disorders and maybe fibromyalgia. So, obviously when we think about what are antidepressants good for? Well, probably a lot of depression, right? And some of these other conditions as well, PTSD, GAD, social phobia, panic disorder, and so forth. It has some other kinds of effects that go beyond that. It has a wide range of utility, but just bear in mind what those things are in theory. And of course the side effects and so forth, and what would be appropriate depending on the circumstances of the patient. Choice of medication. Despite some studies indicating that some antidepressants are more capable of producing remission, the majority of the evidence indicates that all antidepressants have roughly the same efficacy in treating major depressive episodes. Studies historically used response as measured by a depression rating scale to antidepressants. More recent studies have more strictly looked at remission. Higher rates of remission may be achieved with the combinations of antidepressants, but this idea remains unproven. There are several treatment algorithms available for the pharmacological treatment of depression. More research must be done in this area to determine the relative rates of depression remission, particularly in subtypes of patients with depression. SSRIs, bupropion, duloxetine, and venlafaxine, and mirtazapine are the most well-tolerated antidepressants and are generally thought of as a first-line agent for major depression. Compared with TCAs and MAO inhibitors, these medications have very low sedative, anticholinergic, and orthostatic hypotensive effects. These agents should be considered for the use especially in patients with cardiac conduction disease, constipation, glaucoma, or prostatic hypertrophy. Norepinephrine. So here's at figure 12.3. It says here, antidepressant drugs and their biochemical life cycles of norepinephrine and serotonin. So you can see norepinephrine, it has this little vesicle, it goes out, it activates presynaptic and postsynaptic receptors, and it gets swallowed up back in. Or it can be broken down via MAO, monoamine oxidase. Now, we also have this thing right here, it's called serotonin 5-HT. Little vesicle gets poured out, it goes to and activates the presynaptic and postsynaptic receptors, and then it can either go back into the cell, or it can be again broken down via MAO, via the monoamine oxidase. Now that's why we have SNRIs and tricyclics, which inhibit both of the reuptake for both of these. SNRIs prevent the reuptake of serotonin and norepinephrine, and so does the SNRIs. Tricyclics both do that. Both those groups do that. We also have SSRIs, which also do that for the serotonin, but they don't do it for norepinephrine. So SSRIs only do for serotonin. SNRIs and tricyclic antidepressants do both. MAO inhibitors prevent the breakdown of both of these as well. So it's basically a different way to ensure higher levels of them being around, but by preventing breakdown rather than preventing reuptake. Antidepressants are relatively contraindicated in the manic or mixed episodes of bipolar disorder. Among the TCAs, nortriptyline and desipramine have the least sedative, anticholinergic, and orthostatic hypotensive effects. They can be used as first-line agents in younger, healthier people, especially if cost is a consideration. Tricyclics and other antidepressants available in generic form can be much less costly than newer, non-generic medications. Because of the necessary diet restrictions and the risk of postural hypotension, the traditional MAO inhibitors, phenelzine and tranylcypromine, should be used most selectively. They can be quite effective, however, and are used in patients for whom SSRIs and tricyclics have failed. In patients with a concomitant seizure disorder, MAO inhibitors and SSRIs do not lower the seizure threshold, or in those with atypical depressions or social phobias. MAO inhibitors and SSRIs are most effective. High-dose SSRIs and clomipramine, despite its high sedative, anticholinergic, and orthostatic hypotensive effects, are the treatments of choice for OCD. A new skin patch preparation of the previously available MAO inhibitor, selegiline, is available and has demonstrated efficacy in treating depression. Interestingly, at its usual daily dosage of 6 milligrams, dietary restrictions are reportedly not necessary. Therapeutic monitoring. Approximately 50% of patients who meet DSM-4 criteria for major depression will recover with a single adequate trial at least 6 weeks at a therapeutic dosage of an antidepressant. The most common reasons for failed trials are inadequate dose and inadequate trial length. However, dosage and length of trial are often limited by the side effects or noncompliance. Patients on antidepressants should be monitored carefully for side effects of adverse drug reactions, listed under the side effects and adverse drug reactions. Generally, antidepressant therapy of a first episode of unipolar depression should continue for 6 months. Patients with recurrent or chronic depression require longer or perhaps lifelong maintenance treatment. Increasing the dose, augmentation with lithium or triiodothyronine, which is, it says here, liothyronine sodium cytomel, or a psychostimulant, that is to say methylphenidate, switching antidepressants, or addition of a second antidepressant is helpful in treating refractory depression. Patients on most TCAs required serum level measurements to determine appropriate dosing. All patients, but especially children and adolescents, should be carefully monitored for increasing suicidal thinking associated with antidepressant medication treatment. Although antidepressants may reduce the overall suicide rate by treating underlying depression, they may also transiently increase suicidality during the periods of initiation or cessation of treatment, as well as during dosage adjustments. And again, that's sort of a murky concept. It's been proposed that patients who take or initiate antidepressants are more likely to start talking about suicide to their psychiatrists, but it's hard to say whether or not that is because they are thinking about suicide more. It's hard to say that actually translates to them being more likely to commit that. It's sort of a gray area, but they like to err on the side of caution and say, well, it might do this. Just be aware this might be a problem. Side effects and adverse drug reactions, SSRIs. Although specific SSRIs have slightly different side effect profiles, as a group, their main side effects are nausea, headache, neuromuscular restlessness resembling akathisia, insomnia or sedation, and delayed ejaculation and orgasmia. SSRIs combined with MAO inhibitors are dangerous. A fatal serotonin syndrome may result. Tricyclic antidepressants. TCAs in many patients are well tolerated, but because of their side effects, TCAs are less well tolerated overall than are SSRIs, bupropion or venlafaxine. The major side effects associated with TCAs are orthostatic hypotension, anticholinergic effects, cardiac toxicity, and sexual dysfunction. Specific TCAs have relative degrees of each of these effects. Orthostatic hypotension is the most common serious side effect of TCAs. This is particularly worrisome in elderly patients who may be more prone to falls. Anticholinergic toxicity can be mild, including dry mouth, constipation, blurred near vision, and urinary hesitancy, or more severe with agitation, motor restlessness, hallucinations, delirium, and seizures. Cardiac toxicity may limit use of TCAs in some patients. TCAs have quinidine-like effects on the heart, potentially causing sinus tachycardia, supraventricular tachyarrhythmias, ventricular tachycardia, ventricular fibrillation, prolongation of PR, QRS, and QT intervals, bundle branch block, first, second, and third degree heart block, or ST and T wave changes. Well, that is a lot. Major complications of TCAs are rare in patients with normal hearts. TCAs should be avoided in patients with conduction system disease and should be used with extreme caution in patients who have overdosed on medications or have been recurrently suicidal. Sexual dysfunction includes impotence in men and decreased sexual arousal in women. Monoamine oxidase inhibitors, or MAO inhibitors. Patients who take traditional oral MAO inhibitors are at risk for hyperadrenergic crisis from the ingestion of sympathomimetic amines, such as tyramine, that fail to be detoxified because of inhibition of the gastrointestinal monoamine oxidase system. Improper diet can lead to severe hypertensive crises, tyramine crisis, with potential myocardial infarction or stroke. Food that must be avoided includes cured meats or fish, beer, red wine, all cheese except cottage cheese, and cream cheeses, and overripe fruits. Well, that sounds like stuff you wouldn't mind eating, right? The meats and wines and cheese and okay. Many over-the-counter cold and pain remedies must also be avoided. Treatment of hypertensive crisis, if severe, may require emergency medical attention, including IV phentolamine, an alpha blocker, or continuous IV nitroprusside infusion. The noose allegedly patch carries the same risks and as traditional oral MAO inhibitors when used at 9 mg daily or above. At 6 mg daily, however, no dietary restrictions are required. MAO inhibitors cause a dose-related orthostatic hypotension. Tranylcypromine can cause insomnia and agitation. Phenelzine can cause daytime somnolence. What about the other antidepressants? Venlafaxine, Effexor XR, and duloxetine Cymbalta are serotonin and noradrenergic reuptake inhibitors with a better side effect profile than TCAs or MAO inhibitors. Nefazodone and trazodone desoryl are serotonin modulating antidepressants. Trazodone is prescribed rarely as a sole antidepressant, but is often prescribed as an adjunct to an SSRI for sleep because it has strong sedative properties. At high doses, it serves as an antidepressant. In addition to sedation, trazodone can, on rare occasions, induce priapism, prolonged painful penile erection that can cause permanent damage. Patients must be instructed to seek emergency treatment should such an erection occur. Nifazodone is similar to trazodone, but is less sedating at therapeutic doses. It appears to have a low rate of sexual dysfunction, but has been associated with serious hepatic abnormalities. Bupropion, Wellbutrin SR, Zyban, appears to work by inhibiting the uptake of dopamine and norepinephrine. The bupropion has a low incidence of sexual side effects. In addition to its efficacy in treating major depression, bupropion has been shown to be effective in smoking cessation, marketed as Zyban, and attention deficit disorder. Bupropion has a higher than average risk of seizures compared with other antidepressants. The risk of seizures is greatest above a daily dose of 450 milligrams or after a single dose of greater than 150 milligrams of immediate release bupropion. Mirtazapine, or Remeron, is classified as a modulator of norepinephrine and serotonin. It is quite sedating in some individuals and has a low incidence of sexual dysfunction. Somatic therapies. Although all psychotropic drugs are somatic in that they affect a part of the body, the brain, there are a growing number of treatments available that use electrical, magnetic, or photic stimulation of the central nervous system to treat depression. These methods are being studied particularly for treatment-resistant depression, that is to say, episodes that do not respond to several medications serially or in combination. The best studied and most well-known of these treatments is electroconvulsive therapy, ECT, colloquially known as shock therapy. It will be discussed last after newer, more experimental therapies. Yeah, shock therapy gets a bad rap, but it does work in certain circumstances. So, vagus nerve stimulation. Vagus nerve stimulation therapy is approved for treatment-resistant major depression. Although the precise mechanisms of action of VNS is influencing depression are unknown, it is presumed that retrograde conduction of impulses from the peripheral stimulation of the nerve influence central nervous system function. Early findings suggest that the VNS may influence the hippocampus as well as the widely distributed neurotransmitters norepinephrine and the gamma-aminobutyric acid, or GABA. So what they're basically doing is that they're going and putting a stimulator, they're stimulating the vagus nerve, the afferent part of the vagus nerve, like typically out, from what I've seen, which is limited to be fair, the left part of the vagus nerve on the chest, and that has an afferent part on it, and an afferent sensory, and it sends signals back up to the brain. What about deep brain stimulation? Reversible implantable electrical deep brain stimulators have shown some early promising efficacy in small, uncontrolled trials of patients with refractory depression. Stimulation to parts of the frontal cortex and subgenual cingulate has yielded positive results. Large randomized controlled trials will be needed to determine the technique's true efficacy. For now, it remains experimental. Phototherapy. Phototherapy consists of controlled administration of bright lights to treat specific psychiatric illnesses. Phototherapy is administered using specially designed bright light boxes and has been shown effective in the treatment of the seasonal subtype of major depression, also known as the seasonal affective disorder, and in non-seasonal depression as well. Phototherapy is also used in the treatment of delayed sleep phase syndrome and jet lag. In the treatment of seasonal affective disorder, each morning bright light therapy is superior to evening light in most individuals. Light intensity of 2500 to 10,000 lux is most effective. Light therapy can induce mania in susceptible individuals. I'm reading the deep brain simulation stuff because I'm thinking about TMS right now. It's talking about brain simulators, reversible implantable. Okay. I'll talk about that in a brief bit after I read ECT. So electroconvulsive therapy, ECT, formerly known as electric shock therapy, is one of the oldest and most effective treatments for major depression. ECT also has some efficacy in refractory mania and in psychoses with prominent mood components or catatonia. ECT appears to work via the induction of generalized seizure activity in the brain. The peripheral manifestations of seizure activity are blocked by the use of paralytics, and memory for the event is blocked by the use of anesthetics and by seizure activity. Modern ECT produces a short-term memory loss and confusion. Bilateral ECT is more effective than unilateral ECT, but produces more cognitive side effects. So bear that in mind. It has some utility, but there are some issues with it. And I'm going to give you a little bit of my own knowledge of some of these things. This, again, from my knowledge of my psychiatry rotation, is that the psychiatrists that I work with also uses something called a TMS machine. So that's going to be like the use of a magnet on the brain, and that can either be localized with a high intensity, which is a more traditional treatment, or it could use a more globalized, lower intensity treatment. And these can be used for treating depression. So that's called TMS. It was relatively primitive when this book was being written. It says here, TMS is called transcranial magnetic stimulation. It is a non-invasive FDA-approved therapy for treatment-resistant major depression. It is also used, by the way, for PTSD and anxiety off-label. It potentially seemingly increases the cognition of the person because it's increasing the activity of the neurons. So I think it can be quite promising. And basically, you're going through multiple sessions, multiple sessions across multiple days of this sort of device, and that can encourage increased brain activity and help moderate or alleviate your depressive symptoms. So again, that's called transcranial magnetic stimulation. And that is a more recent development in terms of the advances in that. The other one is the use of ketamine and S-ketamine specifically, which is also called, the brand name is Spravato. Now, for ketamine is an NMDA receptor antagonist, and that has been used to treat depression. Again, we're talking about these sorts of depressions that are resistant to other kinds of medications. S-ketamine, we were talking about citalopram and escitalopram. Well, S-ketamine is the S enantiomer of ketamine, and it's going to be more potent and effective than just the racemic mixture of the S-ketamine and the R-ketamine. R-ketamine is less potent, less effective, less useful. Comparatively, to my knowledge, it might be that the R-ketamine has more negative side effects, and that might be the issue. But basically, it's better to use the S-ketamine particularly rather than the racemic mixture of S-ketamine and R-ketamine. It's not going to be as good of a treatment if you do R-ketamine. I think R-ketamine has more negative problems with it if you take the R-ketamine. So basically, ketamine and S-ketamine treatment can also be used to treat patients. And again, then S-ketamine is also called brand name Spravato. Now, I would not be surprised if there's other therapies as well that I'm not familiar with. Just be aware of the fact this book here that was written, this PDF is from what year? 2009. So I don't even think, like, the machine that the doctor that I'm working with, his older machine for TMS is from 2017, I believe, and his newer machine is from like last year. And there's a lot of advancements between there and then. However, 2017 is still, 8 years after 2009. 2009 is like the year that Obama was sworn in. So this is an older book for reference. There's definitely, when we're talking about changes and advances in medicine, there are advances meaningfully so in certain fields. So bear that in mind. Always try to keep up to date, if you will. Anyway, that's the corpus of our chapter. Let's read up the summary. Key points. Antidepressants have multiple indications, including various forms of depression, anxiety disorders, bulimia, and OCD, among others. Antidepressants act mainly on serotonergic and noradrenergic receptor systems. Some antidepressants have been shown to be efficacious for particular disorders. For major depression, all approved antidepressants reduce symptoms to a similar degree. Antidepressants for depression are often chosen based on side effect profile and symptom constellation. Some antidepressants, particularly TCAs, require monitoring of serum levels. The effects of antidepressants can be augmented by the addition of lithium, thyroid hormone, or psychostimulants. Antidepressants have side effects that vary according to class, and the vagal nerve stimulation is used for treatment of refractory depression. So that is the end of our chapter 12, on antidepressant medications. So if you enjoyed that, well, you can always smash that like button or whatever they say, but hopefully it was a good use to you. Regardless, have a great rest of your day,